Good day everyone, I'm Orlin Joshua Limbayugan. I'm your lecturer today for Anatomy of the Spine. So for the osteology of the spine is composed of several sections. We have the cervical composing 7 cervical vertebrae. We have 12 thoracic vertebrae, 5 lumbar vertebrae, 5 sacral, and 4 fuscococcygeal vertebrae. So you have two types of curves in the spine. We have the primary curve composing of the thoracic and the sacral, and the secondary curves, which is composed of the cervical and the lumbar curve. So the primary curves are kyphotic, and the secondary curves are lordotic. The cervical curve develops in humans when the child tries to lift his or her own head. So that's when they develop the cervical lordosis. And when the child starts to walk or stand on his own two legs, that's when we develop the lumbar lordosis. So there are several landmarks for the spine. For the mandible, it's usually located at level of C2, C3. For the hyoid cartilage, it's at level of C3. Anteriorly, you can palpate for the thyroid cartilage, and usually denotes C4, C5 level. Inferior to that, we have the cricoid cartilage at C6, and posterior at the base of your neck, you can palpate for the vertebra prominence, which is the spinous process of C7, and then at level of the scapular spine, usually that's the landmark for T3. At the distal tip of the scapula, it's the landmark for T7, and at the iliac crest inferiorly, it's the usually the landmark for L4, L5. Now we'll be discussing about each of the types of the vertebrae that you would see. So now we'll be discussing about the cervical spine. So when we're discussing about the cervical spine, we divide it into three: the C1 or the atlas, the C2 or the axis, and the C2 to C7. The C1 is also termed as the atlas. It's atypical because it does not have a vertebral body, and it also does not have a spinous process. So it contributes to most of the flexion and extension that you would see in the neck and at the C0, C1 joint. Next, we have the C2, also termed as the axis. It is also atypical because it has what we call the dens, which articulates with C1, providing 50% of the rotation of the neck. Next, we have the C2 to C7 vertebrae, which have foramina in each transverse process, and they also have bifid spinous process, except of course for C7, because it has the vertebra prominence. So the vertebral artery travels in the transverse foramina from C6 to C1. We also have the uncinate process in the vertebral bodies. So that's important as a landmark because when we're doing the anterior approach to the cervical spine, we never go more lateral to the uncinate process because we might injure the vertebral artery. Next, we have the thoracic spine, which is the most rigid part. So its rigidity is due to its rib articulation. Another important aspect of the thoracic spine is its shape of vertebral body, which is its heart shape. It's unique due to its causal facets that articulate with the ribs and the transverse process from T1 to T9. Next, we have the lumbar spine. So it has a greater height anteriorly compared to posterior, contributing to the lordosis. It has larger vertebral bodies, and it also has a mammillary process posterior to the articular facets. So compared to the other structures, it has shorter pedicles and laminae, and it is kidney-shaped. Now for the arthrology of the spine, you have several structures. You have the ALL, the PLL, ligamentum flavum, or the yellow ligament, and the intervertebral discs. So the ALL is found anteriorly to the vertebral body. It is thick and resists extension moment of the spine, so it's thicker compared to the PLL. The PLL is more spread out than the PLL, than the ALL. It's wider and it has more coverage over the discs, but it's weaker at the disc sections. Now for the ligamentum flavum, we usually see it after we do a laminectomy. So it runs from laminate to laminate and it can cause pathologies in the spine when it hypertrophies. You also have the intervertebral discs. You already know this. It's composed of the annulus fibrosus and the nucleus pulposus. Nucleus pulposus is important for resisting compression, while the annulus fibrosus is important for resisting tension. Now we're going to discuss about one important aspect of the spine, which is called the Denis three-column theory. So the gist of the Denis three-column theory is that when there are two columns involved, then we have instability of the spine. So the anterior column, it's composed of the anterior column, the middle column, and the posterior column. So for the anterior column, it's composed of the anterior ligament up to anterior two-thirds of the annulus and the vertebral body. And then we have the middle column from the posterior third of the body and annulus to the posterior longitudinal ligament. And then from the posterior, we have the pedicles, the facets, the facet capsule. Posteriorly, we have the spinous process, the posterior ligaments that include, of course, the interspinous ligaments, supraspinous ligaments, and the yellow ligament. Now we have the specialized joints for the spine. So the first one would be C0C1 or the atlanto-occipital joint. It is composed of two capsules, anterior and posterior capsule, and of course the tectorial membrane. And then we also have the atlanto-axial joint, which is composed of the alar ligament, the cruciate ligament, the apical ligament, and most importantly, we have the transverse ligament. So again, the atlanto-occipital joint gives us 50% of the flexion extension of the neck, while the atlanto-axial joint gives us 50% of the rotation of the neck. Next, we have the muscles of the neck. So the important ones would be the following. So on the anterior border of the neck, you'd usually see these muscles. They are bordered by the anterior neck, the sternocleidomastoid muscle, and of course the mandible. So the strap muscles are composed of there are two strap muscles. The superficial ones are the omohyoid and the sternohyoid. The deep strap muscles are the thyrohyoid. And lastly, we also have the sternocleidomastoid muscle, which is important because it moves the neck towards the contralateral side. Next, we have the muscles of the back. So we have two main blankets for the muscles of the back. One would be the trapezius muscle, which covers the upper back, and the latissimus dorsi, which covers the middle to lower back. We also have the rhomboids, which are deeper than the trapezius and the latissimus dorsi. And finally, we have the last layer, which are the erector spinae, which allow extension of the back, which extend from the transverse process of the more inferior vertebral body up towards the spinous process of the superior vertebrae. Now for the spinal cord itself, we have 31 pairs of spinal nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. So below L1, the nerves are contained within what we call as the cauda equina. So usually the spinal cord is, if you can notice the levels of the spinal cord, in the cervical spine, the corresponding nerve root exits above the space between the vertebrae. So for example, the C6 nerve root exits at the level of C5, C6. When you compare this to the lumbar spine, the nerve root exits below its vertebrae. So the L5 nerve root actually exits at the level of L5S1. So that you would see those pictures in the rightmost aspect. Now, for the spinal cord orientation, we need to be a bit familiar with this. As you can see, we have the lateral corticospinal tract or the motor tract. We have also have the lateral spinothalamic tract or the sensory for the pain and temperature, and we also have, of course, the posterior column, which provides position sense. So, um, the lateral corticospinal tract and the lateral spinothalamic tract are are all supplied by the anterior spinal artery. So when you have damaged the anterior spinal artery, then you have loss of the motor and the pain and temperature sense on that level. Now this is what we typically use for testing our patients with paralysis or with the spine injuries. So this is what we call the ASIA scale. So these are the representative levels that we use. For C5, we have the elbow flexors. C6, we have the wrist extensors. C7, we have the elbow extensors. At C8, we have finger flexors. And then at T1, we have the finger abductors. And then for the lower extremities, at L2, we have the hip flexors. L3, you have the knee extensors. L4, ankle dorsiflexors. L5, long toe extensors. And S1, the plantar flexors. So these are all very important to remember. So one thing also important to remember, of course, would be the sensory areas for the spine. So at T4 we have the T4 innervates the nipple area, the T10 innervates the umbilical area. Below that we have the L1 which innervates the anterior inguinal area, and then for the key sensory points, um, those are the more important ones. Now we have scaling for the muscle strengths. So for Asia scale, we have complete. We have two types or three types. I mean, we have A, B, C, D, and E. So A or complete paralysis, the patient has no motor, no sensory, and no sacral sparing. For B or incomplete, the patient has no motor and but has sensory only. For C or incomplete, 50% of muscles have less than grade 3 or cannot raise arms or legs off of the bed. For D, we have 50% of muscles more than grade 3 or his arms and legs can be lifted off the bed. And then we have E for normal. Motor and sensory functions are normal. Now, lastly, we have the blood supply to the spinal cord. So the distance from the spinous process at C1 laterally to the vertebral artery is usually 2 centimeters. So we never extend beyond 2 centimeters at the posterior aspect. And finally, we also have the artery of Adamkiewicz, which is important because it supplies the anterior two-thirds of the spinal cord. So this artery enters through the lower thoracic vertebrae and supplies T8 to T12.